Welcome everybody. We're having a slight change in tack now, going from a very complicated situation in pregnancy with twins down to something that probably most of you see frequently. And I'd just like to thank the organisers of the workshop and Issuog for inviting me to talk. So this is really a very basic and practical talk. The question is, vaginal bleeding in the first 10 weeks of pregnancy, how can ultrasound help? So ultrasound is really, as you all know, integral to the management of early pregnancy complications. So first of all, the main role of ultrasound is diagnosis, and the two issues are to locate the pregnancy and to determine viability. And I'm going to go through both of these separately. And then ultrasound also has a role in treatment, which I'm not going to go through in as much detail because I think that's more management, and we're really talking about ultrasound today. So in anyone who has vaginal bleeding less than 10 weeks, the initial ultrasound scan is actually the test of the main test that should be being done. Why? It will locate the pregnancy in 70 to 90% of cases with one ultrasound scan done transvaginally. So what do we mean by locate the pregnancy? Obviously, we want to know if it's intrauterine or extrauterine, and as you can see down the bottom, or we don't know where it is. So it's a pregnancy of unknown location. So in 70 to 90% of the time, the first ultrasound scan you do will locate the pregnancy and tell you whether it's intrauterine, extrauterine, but in 10 to 30% of early pregnancy bleeding, you will not locate a pregnancy. So they will have a positive beta HCG and you can't see any evidence of a pregnancy. That is called a pregnancy of unknown location. So we've done our scan and we've found that there is a gestation sac in the uterus. So we've located that it's intrauterine. How are we going to know whether it's normal or not? And I'm not going through normal pregnancy because normal pregnancy you should all recognise. You see a fetus and a fetal heart. But let's look at abnormal pregnancy. So if you have an abnormal intrauterine pregnancy, in other words, you can't see a fetus and a fetal heart, what should your approach be to that? So two things that are really important to start with. Can you see a sac, or is there no sac, but there's a mass in the uterus? So these are the first things you need to look at. And then if you see a sac, you need to measure it, and we'll talk about that in a minute, because you're going to then have to decide, is this uncertain viability, in other words, this could become a viable pregnancy, or is this definitely an early pregnancy loss? If it is an uncertain viable pregnancy, then eventually it may become normal or it may become an early pregnancy loss, and that's where the ultrasound comes into its own in follow-up. And with a mass in the uterus, I'm not going to talk about moles, but we're going to talk about incomplete and complete miscarriages. So what are the ultrasound criteria for distinguishing between a pregnancy with uncertain viability and an early pregnancy loss? And these have recently been changed internationally, but ASM has accepted the new definitions, and these are those. So if we're defining viability, it's easy. It's a gestational sac with a fetus and a fetal heart present inside the uterus. A non-viable pregnancy, which is also an early pregnancy loss, is a fetus with a crown rump length greater than or equal to 7 millimetres with no fetal heart seen. So that's measuring the fetus. The second definition of a non-viable pregnancy or an early pregnancy loss is if there's no fetus in the sac, then you measure the sac, and if the sac is greater than or equal to 25 millimetres with a mean sac diameter, and I'll explain that, with no fetal pole, that is also a definitive diagnosis of an early pregnancy loss. So, of course, the converse applies. Pregnancy of uncertain viability is a pregnancy where there's a crown rump length that you can measure, but it's less than or equal to 6 millimetres with no fetal heart, or there's no fetus in the sac and you've got a mean sac diameter less than 25 millimetres. So let's go on and explore these a bit more. So just to reiterate, this is really important that you know these numbers. So you put on your M mode, you see a fetus, you put on your M mode cursor, or you're looking on real time. You must be able to see a fetal heart when the crown rump length is greater than or equal to 7. So if you see that, if the fetus measures 7 and you don't have a fetal heart, it is an early pregnancy loss. And if it's less than that, less than 7, then you should be waiting. So this is an example of a early sac in a uterus. So this is the uterus here. This is the midline. This is the sac, and in here is a fetus. Now the colour's on here only to show you that there's no fetal heart. So I don't normally use colour to demonstrate the fetal heart, but seeing these are still images, that's just what I've done. So if you measure, and when you're measuring a crown rump length in these early stages, it's always the longest measurement that you use, excluding the yolk sac. So it's very important to measure the fetus, to rotate your transducer very slightly so that you get the longest plane, and then make sure you don't have the yolk sac included in your length, and then do the measurement 3 times, and the best of the longest measurements is what you use. So this measurement was 7.5 millimetres. There was no fetal heart. So this is, by our definitions we've just been talking about, non-viable or an early pregnancy loss. Similarly, that you can see the yolk sac here. So this is a little tiny fetus. It's measured in the longest length. This is the head with the rhombencephalon here. You'll often see this anechoic area in the skull. This is the early brain, so that's normal. That is part of the fetus. And you have to distinguish that from the yolk sac, which in early pregnancy is right next to the crown rump length. So it's very easy to mistake it for part of the fetus. So we measure from the head to the rump. This is 10 millimetres. There's no fetal heart present. This is a definitive early pregnancy loss. Similarly, this one, and so what I'm showing you is fetuses that look a bit different. This one looks a bit like a blob. This one you can really see does look like a little normal fetus. This one doesn't. It's quite sort of hydropic looking, but still measure from the head to the rump, 10 millimetres, no fetal heart. This is an early pregnancy loss. And this is the yolk sac. And you can see here, this is also the amniotic membrane that you can usually clearly see too, particularly if you're doing this transvaginally. So let's look at sac sizes. So this is a uterus here. We've got the sac in. You can actually see this is the amniotic membrane. There's no fetus that we can see in here. So the mean sac diameter, so this is measured in 3 planes. The mean sac diameter is 25.4. There's no fetus visible, so this is a definitive early pregnancy loss. So this is showing you the 3 measurements to calculate a mean sac diameter. You just do three measurements and divide them by 3. So we're doing longitudinal, here's a longitudinal plane and here's a transverse plane. So we're doing across, down, and then the 3rd plane, divide it by 3. This mean sac diameter is 36 with no fetus, nothing. There's nothing in this sac. There's no amniotic membrane, no yolk sac. This is what was called a blighted ovum in the old days. That termination has gone. We now use early pregnancy loss to cover all of these things, and it's greater than 25 millimetres, so it's a definitive early pregnancy loss. Okay, so let's move to the converse of this, uncertain viability. So these are 2 fetuses that were seen in early pregnancy that subsequently developed fetal hearts, that fetal heart motion that was not there at this really early stage. So it's really important you don't label these as non-viable. So this is, you can see a really tiny little fetus that's 1.7 millimetres, and this one's 3 millimetres. So it's important if you see a fetus that's not yet 7 that you wait. So the general rule of thumb is that you wait a week. You can wait longer, but certainly don't rescan them within a week if they're this small. So if we're looking at sacs and no fetus with uncertain viability, what are the clues that this may be a normal pregnancy that is going to develop into viability if you wait? So this is I'm going to use this as our example. This is a uterus, anteverted. This is the endometrium. So this is your decidua. You can see very clearly a midline coming across here, and you can see a very tiny little sac eccentrically placed in the decidua. So the rules for normal, very early pregnancy are that there is an intact midline, that the sac is eccentrically placed in it, that there is trophoblastic reaction around the sac, that's this white rim around the sac, and that the sac is less, that should say 25, sorry, that's the old criteria, less than 25 millimetres with no fetus, or the fetal pole less than 7, sorry. So here is our little sac here, and it's 5 millimetres. Now, you're not meant to be able to see a sac before about 4 millimetres, so this is really, really early. We're looking at a pregnancy that's somewhere between 4 and 5 weeks amenorrhea to see this sort of image. Again, here's one that's really, really tiny, just visible. Another one, 10 millimetres. You can see again, it's eccentrically placed in the decidua. This is the whole of the decidua here. Here's our midline, and here's our sac with a trophoblastic reaction around it, and there's even a yolk sac in this. So this is, we don't know, this may be in a week or 10 days look exactly the same as this, which would be non-viable, or it may have developed and be a normal pregnancy. Similarly, this one, here we have our uterus, this is now retroverted. This is our decidua. We have a sac that's 17 millimetres mean sac diameter. We're going to be waiting. Okay, here's one of our little sacs. It's 10 millimetres. So what are we going to do to confirm or refute viability? And as I mentioned, we're going to scan in 3 to 7 days. And in 3 to 7 days, it looks exactly the same. And if you plot the mean sac diameter against gestation, you can see that in fact this sac over that period of time has diminished in size. Often they'll stay the same. Sometimes they will grow a little bit, but you won't develop a fetus. So this is definitively telling you that despite the fact the sac is still less than 25, over 10 days it has not increased in size. So this is also an early pregnancy loss. Whereas this little pregnancy with its yolk sac, 7 days later, we have a much bigger sac. We have a fetus with a fetal heart of 122. So this is now a viable pregnancy. So moving away from normal or abnormal intrauterine pregnancies to actual miscarriages, what are the ultrasound criteria for distinguishing an incomplete miscarriage? So the RCOG criteria is that it is an incomplete miscarriage if there is a mass in the uterine cavity with an AP diameter of greater than 15 millimetres. So you don't need to measure volumes, you just do a longitudinal view of the uterus, you measure what's in the uterus, and if it's less than or equal to 15, it's a complete, and if it's over 15, it's not. Now, I want to make some, expand on this. So an incomplete miscarriage, the endometrial AP diameter, so this is a longitudinal uterus. We have the lining of the endometrium here. We have this tissue in the middle. So we have, and you can see here the same. This is the endometrial cavity with echogenic tissue in it. So the difference from looking at an early normal intrauterine pregnancy is that the midline is disrupted. So with an incomplete miscarriage, you cannot see a midline. So you see all this heterogeneous tissue without a midline. It's usually heterogeneous. It's not even. You get areas of dark, very echogenic, and it's often moving on real-time imaging because there's blood in it as well. So this, again, you can see a very big mass in this uterus. It's 38 millimetres in AP diameter. So all you are doing is measuring from front to back. It's a very simple thing to do. You get the biggest diameter of your mass in the uterus and measure it. So I'm not going to tell you what to do, but often we are waiting with these now. But you would follow an incomplete miscarriage up because you would want to make sure that they had actually passed the tissue. Certainly if they come back bleeding, you may consider doing a curette, particularly if there's as much tissue in the uterus as this. So what's the difference with a complete miscarriage? So this sort of appearance, if someone turns up or is in your office with early pregnancy bleeding and you scan them and this is what you see and they have a positive pregnancy test, this is the real dilemma, because you do not know with this sort of thing what you have. Do you have an ectopic? Do you have a complete miscarriage? Do you have a really early pregnancy? So with this, you can see that it does look like the midline's disrupted, so that's giving you a clue that this may be not a very early normal pregnancy. There's a bit of dark in here, a bit of blood. So you're really interested in is this an ectopic? So is this just a decidual reaction, or is this a complete miscarriage? So certainly you want to measure across it so that you've got your baseline, but you have to be very careful about making the diagnosis of complete miscarriage without prior ultrasound documentation of an intrauterine pregnancy. So if they've been for a scan somewhere else and it's shown an early sac and they come to you and it looks like this, you can be quite certain that this is a complete miscarriage. But all of us have had our fingers burnt with this. You need to be careful that when diagnosing a complete miscarriage, when an intrauterine pregnancy has not been seen previously, that this is not an ectopic. And it's well documented that ectopics occur, sort of round about the 5% mark in this situation. So, and then of course in the back of your mind, way, way down the list, is heterotopic pregnancy, in other words, an intrauterine and an ectopic concurrently. But this is really the main differential that you must think about. And for that reason, if you diagnose a complete miscarriage, it's very important that you follow the woman up and that you follow the HCGs down to negative. So what are the ultrasound criteria for distinguishing an ectopic pregnancy? So just like our complete miscarriage, you have what is defined as an empty uterus, no sac. You have an adnexal mass. You may or may not have free fluid in the pelvis. Hopefully you don't. And you should always try to visualise the ovaries and locate the corpus luteum, because the vast majority of the times the ectopic is on the side of the corpus luteum. It's not absolute, but it's certainly by far the majority of cases. And also, sometimes the corpus luteum can be mistakenly diagnosed for an ectopic, so it's really important to see the corpus luteum and the separate adnexal mass. So, first of all, the empty uterus. So the empty uterus in an ectopic can have very, very variable appearances and certainly is not a clue at all to whether the pregnancy is ectopic. It's just the fact that it's an empty uterus must alert you to the fact that it might be an ectopic. So here we have an anteverted uterus that's paper thin and you can see a midline in it. So looking at this uterus, you'd wonder if someone was pregnant at all. Then you have this appearance, which to me just looks like a complete miscarriage. It's a disrupted midline, and remember that the decidua in an ectopic bleeds, so it is often disrupted and looks just like an incomplete or a complete miscarriage. Here we are, here's another retroverted uterus with a midline present, but a bit of bleeding going on here. And here in this one, you have a very thick decidua with no midline. So all of those can be present in an ectopic. So what does the adnexal mass look like? And I'm going to show you lots and lots because they can look very, very variable. So probably the most common is referred to as the ring or the donut sign. When you're looking for an ectopic, it's important to look in the right place, and the right place is between the uterus and the ovary. It's called the ectopic angle. So if you're scanning in a transverse view, scanning up the uterus, then you scan out to the lateral pelvic side wall and find the ovary, then you literally scan up and down in that plane, looking all the way between the uterus and the ovary at all levels of the uterus. So these are transverse images. So here is the uterus, and you can see this little tiny donut or ring. So you have an echogenic mass with a little tiny gestation sac in the middle. Again, another one, mass. You can see how often they get lost in surrounding bowel, so they can be quite difficult to see. And it's important to see the bowel undergoing peristalsis around it, which is very obvious, and you see a mass that isn't. Here's a big one that has a yolk sac in it, but they don't usually look like that. They much more often look like that if you're seeing them early. So sometimes you'll see internal structures. So obviously it makes it a lot more easier for you to make the diagnosis if you see a rim. So this one's very subtle, but you can see a tiny little yolk sac here. Here you've got an ectopic with an actual fetus in it, and here is your separate ovary. So uterus over here, ovary here, these are your iliac vessels coming up here, and here's your little ectopic sitting in the ectopic angle between these. So what is the other appearance of an ectopic? So you might not get a ring or a donut. You might get this really heterogeneous mass, so without a sac, and this is usually a hematosalpinx. So it's still an ectopic, but you haven't got a sac. You've just got this, this sort of uniform mass. And here you can see again it's still in the same place. Here's your ovary here, your uterus here. I mentioned you might see fluid. So this is very heterogeneous fluid. So this is blood. So it's important to recognise the appearance of blood. And this is just to show you what it looks like put together. So our three criteria: empty uterus, ectopic pregnancy, corpus luteum. So here's our uterus. We've got our endometrial lining that's got a bit of bleeding in it, quite thin. We've got so the corpus luteum is often more obvious because it really lights up when you put colour on it. You get your ring of fire, and here sitting next to it is an ectopic pregnancy that has a bit of flow in it, but not nearly as dramatic as the corpus luteum, which it's sitting next to. So similarly, here's another one. We have our uterus sitting up here. This is the ovary with the corpus luteum, and here's our little ectopic pregnancy. Okay, so this is a case that, just to show you that you do need to always be careful. This is bleeding less than 10 weeks gestation. This is a nice little uterus. Look, you can see a lovely little gestation sac. There's a midline. Oh, this is going to be possibly a viable pregnancy. Looked at the ovaries, corpus luteum on one ovary, corpus luteum on the other ovary. So this was an IVF pregnancy. Be very aware of this. And here we are. We have our little ectopic. So this is a heterotopic pregnancy that has both an intrauterine and an extrauterine pregnancy. Beware IVF pregnancies. Okay, so just to summarise, we have your scan. You're either going to know where the pregnancy is immediately on your one scan. It's going to be intrauterine, which means it's either going to be normal or not normal. But not normal means it still may become normal if it's an uncertain viability or an early pregnancy loss, or you're going to see an ectopic pregnancy on your first scan and you will know, or it's going to be unknown. Now, very quickly, what are the criteria for a pregnancy of unknown location? So, uterus empty, no sac, endometrial AP diameter less than or equal to 15 millimetres, ovaries visualised with a corpus luteum, and no adnexal mass seen, and obviously an HCG positive. What are the outcomes? Everyone gets very worried when they don't see a pregnancy. What are the actual outcomes when you're at your first scan, you have a pregnancy of unknown location? Well, some of them will be normal intrauterine, some miscarriage, some ectopic, but by far the most resolve without you ever knowing where they are. So it's very important to know that. And so for that reason, it's important to follow them up, usually expectant management. You can do other things. You can do a serial HCG. Some people will do progesterones. It's important to follow them up with ultrasound and continue until the HCG is 5. So obviously things are going to change and you'll develop an intrauterine pregnancy, an ectopic on ultrasound, or an early pregnancy loss. But if they stay as a pregnancy of unknown location, they're probably going to disappear without you ever knowing where they are. And there's very good evidence now that that reduces hospital admissions, reduces unnecessary operations, and has a detection rate for ectopics approaching 100%. So in conclusion, the place of ultrasound in bleeding before 10 weeks is that it's the most accurate diagnostic test. One scan will locate the pregnancy and assess viability in 70 to 90%. It's important to follow up pregnancies of unknown location and uncertain viability for making your final diagnosis. It contributes to treatment, and it's important in monitoring conservative and medical management of early pregnancy and miscarriage. Thank you.
That was fantastic. Anyone got any questions of Janet? No? Oh, sorry, yes?
When you don't see a fetal pole, is there any value in looking at the yolk sac with PD or 4D?
Obviously, if you don't see a yolk sac, you're not likely to ever develop a fetal pole, but at the end of the day, it's about looking at, you're meaning to see a tiny little fetus next to the yolk sac? Is that what you're wanting to see? Look, at the end of the day, you still need to see a fetal pole. So you still need to wait to do a fetal pole.
No more? Thank you, Janet. That was fabulous. Our next speaker